Good morning, everyone, and thank you for giving me this opportunity to speak on Rhexis runout and then what. So we all know that complete Rhexis is a prerequisite for good FECO, a perfectly sized Rhexis and position CCC for premium IOLs is a requisite, and Rhexis runout happens in 0.8 to 0.1 to 5.5% of cases, and Moorfield study shows the incidence of 1.55. So in experienced hand it can run out, but most commonly it runs out in intimations cataract. But in experienced hands, because of brushing and lack of concentration is another factor which we have to keep in mind, and other causes are pseudo exfoliation and pediatric cataracts. So prevention is better than cure. So as I have said, intimations cataract is the most common type where it runs out. So there are certain things which you have to keep in mind, such as staining the capsule with trypan blue, flattening the capsule with good cohesive OVD, and decompressing the central intralenticular pressure by a needle, as I will be showing in this video. What I am doing after OVD, I am going in, and at the same time, just before puncturing, I am aspirating as well, so that the intralenticular pressure is decompensated. And you can see the Rhexis is going in a different direction, but it will not run out. But then I'll do a small Rhexis. Why a small Rhexis? Because in the middle, in the periphery, the pockets are not broken yet. So if I try to do a big Rhexis, it can go out. So I'm doing a small Rhexis. Now I will go in and break the pockets in the periphery. So this is important. There are different techniques. This is the techniques which works better in my hand. That's why I'm sharing this. Once this is broken, I go in with a Venus scissor. I give an oblique cut. Make sure the cut is oblique and not perpendicular to the Rhexis, because then again it can run out. And then I can extend the Rhexis according to my choice. So this is how we prevent. Now if it goes out, so it's not a light, if you can put the light down please. Now you can see the Rhexis is going out there. It has gone out there. What to do? So best thing, put in OVD. The OVD should be put where the Rhexis is running out. Increase the magnification, and you have to flatten the Rhexis. You have to put the Rhexis back. The everted flap has to be put back, and then you have to pull it in and try your luck. So here I am putting the flap back again and pulling a quick jerk, pulling it to the center, and the Rhexis is rescued. The next slide also shows the same thing. Here I was probably a bit casual. Everything was going on, and then it extended there at about 3 o'clock position, it extended. So again, the same principle follows. So you go in, put more visco where the Rhexis was running out, flatten the capsule there, and then pull the Rhexis in. So I have flattened the capsule, going with the forceps there, and a quick jerk to the center, and that is rescued. So that's how we rescue a runout Rhexis. Now you have to be vigilant as well. Here everything was going fine. I was about to come out, and the Rhexis forceps got stuck with the capsule, and the capsule pulled out. Now I thought, okay, I was vertical, so it might not go out, and I was right. So what I did, instead of panicking that the Rhexis has run out, I put whatever was out, I tried to put it back, and basically because it was vertically I was holding it, the iris actually prevented the Rhexis to run out completely, and I managed to rescue it. So you have to be vigilant as well. Now if it runs out, what next? So it depends on the surgical expertise, grade of the nucleus, comorbidity, then you have to decide whether to do it in bag phaco or iris plane phaco, and about the iris IOL placement as well. So these are the few things which you decide. Now in this case, what went wrong? Let's see. So on the left hand side, I have enumerated the principles of following, but here the first steps went wrong. The staining was not good. What I should have done, I was a bit callous. I should have gone in and stained it again. But instead of doing that, I tried to do the Rhexis. It was going on fine. I have done the decompensation. I am doing the Rhexis, but then because of lack of staining, it went out. And I realized that when it went out, it has gone out at 2 o'clock. And because it is close to the sub incision thing, I couldn't rescue it back. So there are several ways of managing this stage. Once you can go in from the other side and bring the Rhexis in there, or you can cut with the venous scissor and complete whatever Rhexis is there, but you have to remember your capsule is open there, your bag is open there. So principle you have to follow here is minimal lateral separation, working away from the tear. Here the tear was at 2 o'clock. Try to maintain the anterior chamber as much as possible and look for Rohit Amparkar sign. Sorry for the mistake in the name spelling. And if the flap is, if the extension flap is fluttering, then you are sure that it is not gone as a wrap-around tear. But if it is taut, then you have to be cautious and you have to move to plan B, either ECC or anterior planar phaco or SICS in those situations. So if the flap becomes taut, that means it is becoming a wraparound tear. And you can see how slowly I am progressing. I am chopping very slowly, trying to do the phaco slowly so that the Rhexis, so that the chamber is maintained well and so that the extension, it's not going beyond the extension. So for the lack of time, I'll move to the next slide, but you can see the principle is to do slow phaco as much as possible, work away from the tear. And here again, it was a straightforward case. No staining was required, but I lost the capsule again, probably because I was not using the right OVD, because I was using HPMC, which was leaking from the anterior chamber, and I lost the flap. So again, in this situation, I tried to rescue it, but I couldn't. And what next? I tried, because you can see my pool was not right. It was not towards the center. This is helps when you audit, re-audit and go back to your video. My pool was not right. It was not towards the center. So what I did, I made a nick on the capsule and rescued the Rhexis from the other side. Just few seconds, one more slide, give me few seconds more. So I rescued the slide from this side to complete the Rhexis. And then I had to nick again to enlarge the Rhexis on the other side so that I get good access to the nucleus and carry on with the phaco as required. Just few seconds more, one more slide.
All of us have faced this type of problem. I think two things are important to
just
prevent.
Just few more seconds, yeah. So this is another Rhexis. Again, I didn't use the right OVD. It extended here, and again I had to do the same technique of rescuing. Because of lack of time, I'll skip this. And sometimes it shouldn't happen nowadays. Argentine flag sign. If you are decompressing the capsule well, you shouldn't have. But this is an old video where I had this Argentine flap sign. Here, again, you have to have a good access to the nucleus. So you nick the capsule, get a hemirhexis done, and then you nick the capsule again on the lower side, on the upper side, and get the hemirhexis down. Fortunately, this type of cataracts are quite easy to chop. So it's most of the cases, if not all, you can go ahead and do the phaco and complete the phaco. But again, the principle has to be followed. You have to keep sure it's not extending by looking at the flap sign. Do slow phaco and try, if you have 3-piece lens, give it on the sulcus. Otherwise, the option is giving single-piece lens on the preserved hemirhexis. Thank you so much for your patience hearing.